I'm introducing Dr. Michelle Himan. She's a dedicated hematologist at Ampath, where she combines her passion for science with a special interest in coagulation. Her journey began at the University of Pretoria, where she earned a BSc in Human Physiology, followed by a Bachelor of Medicine and Surgery. She went on to serve her internship and community service at Tembisa Hospital, gaining valuable hands-on experience in patient care. In 2021, Michelle completed her postgraduate studies in Haematology at Sefako Makgatho Health Sciences University. Always eager to expand her expertise, she recently earned a distinction in the Principle of Patient Blood Management course, hosted by the University of the Free State. Thank you so much for coming to present this to us.
Thank you so much, Leanne. Thanks for having me here. So today I'm going to talk about hematology in sports medicine. It's quite an interesting topic, and with a few changes occurring in the hematological system in athletes. So the outline for the presentation, I'm going to talk about the effects of athletes on the red blood cells, or sport and exercise on red blood cells. It's going to be dilutional anemia, and the most common iron deficiency anemia, as well as March hemoglobinuria. I'm going to touch on the white blood cells because we do get athletes with neutropenia and lymphopenia can occur. And then one slide on the platelets to explain that thrombocytosis and platelet activations can occur in strenuous exercise. And then at the end of my presentation, I'm going to just talk about blood doping, erythropoietin stimulating agents available for doping, as well as blood transfusions that's being used. And then end off with my references. So to start with the red blood cells. So first of all, the definition. Anemia is classified as a reduction in the hemoglobin concentration, as well as the reduction in circulating red blood cells. So in athletes, this is quite important because it's your red blood cells carrying the oxygen, supplying the muscles with the needed nutrition. So as we all know, the athlete's main aim is to increase the red blood cells and oxygen delivery to increase performance. So you do want to monitor your athletes for the hemoglobin value. So the World Health Organization graded the severity of anemia in the following groups. As you can see, a mild anemia in adult men is below 13 grams per deciliter, and an adult woman below 12. It's very important, even if the patient is not athletic, if you do present with the patient in front of you that has a mild anemia, to actually investigate for the cause. This is just to prevent any future side effects or obstacles that can occur. If you do have a patient in front of your practice, a male, and the HP is mild anemia, kindly investigate, because you don't know in the future if the patient's going for theatre. So you want them to have the optimal HP to prevent any complications occurring in the future. So one of the common anemias that patients can get in athletics is actually sports or dilutional anemia. This is a decrease in the hematocrit and hemoglobin and red blood cell count, and this is caused by endurance training. It is usually explained by exercise-induced plasma volume expansion by 10 to 20%, and this takes place within a few days of extensive training. But in the meantime, the absolute hemoglobin mass is increased by physical effort. It's stimulated by aerobic decreases, but this mechanism is outpaced by the plasma expansion. And this is when you get dilutional anemia or spheroanemia. It's not a true anemia, and it's usually caused by the increase in plasma volume in response to exercise. Could be due to the increase in aldosterone, renin, the arterial natriuretic factor, vasopressin, as well as the increase in renal retention and of water and salts. There's also the increase in plasma proteins, albumin increases, as well as an increase in hydration because the athlete is drinking more. This will result into a dilutional anemia. So how do they present? Usually you'll see a mild anemia in these adults after strenuous exercising, as well as females, but it will resolve within 3 to 5 days when they actually rest. There's no treatment for dilutional anemia. It does not negatively affect the athlete performance, so no treatment is required. Then moving over to our iron deficiency anemia, I know Leanne gave a very nice presentation on iron deficiency, so I'm going to touch a little bit on this. And I used the following journals for this section of the presentation. Also, I just want to pay your attention to a new journal that's been published like a month ago by the University of Cape Town. As you can see, Professor Jessica Opie and Vernon Lowe presented this. And this is also for you guys, it's freely available, but they actually use nice case studies where ferritin levels are increased for these difficult patients with heart failure or chronic diseases where the interpretation of iron studies can be difficult. So this is quite a nice journal that I've also used for implementing the iron studies. So what is iron deficiency anemia? So this is actually the most common cause of a true anemia in athletes. It affects about 52% of female adolescent athletes, 30 to 50% athletes participating in endurance sports, and then 5 to 15% of male athletes are also iron deficient. So this is actually also quite scary. As you know, they're not menstruating, so it must be due to the increase in demand and breakdown of red blood cells that's not being fulfilled with the increased intake. So it's also found in athletes of heavy training loads for long middle distance runner, as well as also team play sports like rugby. So the primary cause is insufficient iron uptake from the gut, or it could be increased loss. Blood is usually lost in women via the menstruation or gastrointestinal tract. It's also important to know that these athletes can also take non-steroidal anti-inflammatory drugs that can induce gastritis, and that's frequently seen in athletes. And also it could be due to the increase in hepcidin hormone because of the strenuous exercise. The hepcidin hormone is increased, blocking the ferroportin, and at the end you can present with an anemia of chronic disease or anemia of chronic inflammation. And this is actually just a response to chronic exercising. Another important factor is that sweating may also lead up to a loss of 2.5 micrograms of iron in a liter of sweat. And then another important factor where you can lose iron is hematuria. This is you in long distance runners, where there's actually contusion of the posterior bladder wall to the neck of the bladder that's fixed, and you can actually then detect hematuria in the blood. And then also you can get intravascular or extravascular hemolysis. I'm not going to go into too much detail, but just to recap again about the intestinal absorption of iron. As you know, we get iron available in the heme form, the ferrous, and the non-heme form, the ferric. And I just want to show you with the heme form being absorbed by the heme transporter and being degraded by the heme oxygenase before moving to the ferroportin main channel of iron via the duodenal villi. It's important to see that the non-heme ferric iron needs to be reduced and then again oxidized before being bind to the transporter, the transferrin transport in the system. And the main regulator of iron absorption is actually hepcidin. It will block your ferroportin on your duodenal and jejunal areas of release of iron, but also the macrophages in the liver and spleen. So if your hepcidin levels are increased, it will block the absorption of iron. And just to focus more on hepcidin, there's a few factors that will actually increase the absorption of, or increase the production of hepcidin. As you can see, if there's a chronic renal disease with decreased glomerular filtration rate, the hepcidin will increase, and it will actually then also block the iron absorption, and that's when you get the anemia in chronic kidney disease patients. Also, when there's a recent red blood cell transfusion, there's a spike in hepcidin. If you also take iron supplements, if there's sufficient iron stores, the hepcidin will be increased. And then also you can get genetic factors that will increase, or genetic diseases like hemochromatosis, where the hepcidin could be increased. And then also remember your normal evolutionary protection against organisms. If you've got an infection, your hepcidin will increase to decrease the absorption of iron available for microorganisms. If there is ineffective erythropoiesis or your bone marrow is actually being producing red blood cells, you will get an inhibitor of hepcidin. And this is just to actually to assist your red blood cell production. You'll get it in a state of hypoxia or EPO that's actually needed to increase the stimulation of red blood cells. And then another thing is also chronic chronic liver disease. And that's why you see patients with alcohol abuse and chronic liver disease has actually got an increase in iron storage. And that is usually because the hepcidin is not produced. You can also get it, hepcidin is lower in the use of estrogen or testosterone, as well as chronic hepatitis C. So there's a lot of factors actually affecting the iron absorption by the hepcidin hormone. And then just, I've spoken now about the absorption and the factors that could affect hepcidin. And then how do a person actually develop anemia? So it's very important to know that if your stores are normal and your red blood cell form is normochromic, normocytic, we've got sufficient iron stores, but then you get a latent iron deficiency. It's the next step is where your stores are depleted, but your HB and your red blood cells are still within normal size. And then when your stores are depleted, as well as the iron to supply the formation of the red blood cells are affected, you'll get the microcytic hyperchromic anemia. Giving you the full-blown morphological features of an iron deficiency. Also, just to note that in your latent iron deficiency, when your stores are low, you can actually also present with fatigueness, depression, and the signs of iron deficiency. And just again, like what I explained at one slide, is when you get your iron deficiency without anemia, it will show a decreased ferritin, but your level of hemoglobin will be normal. It is very important to actually screen for low iron stores at the start of a training program in a female, because if you can supply iron in these patients, it will actually improve their performance. Because not only if their storage are low, they will struggle with cognitive function, as well as depression, and also their performance. So it's best to test actually twice a year the iron studies in endurance athletes to make sure that they're not iron deficient without anemia. Usually these patients, you'll give them a trial of iron and then monitor them. And then for the iron deficiency anemia, we know that the WHO is defined when the hemoglobin is less than 13, like I mentioned, for male and 12 in a female. And also the MCV and the MCH will be low, with the serum ferritin less than 45 micrograms per liter. And this ferritin level is very sensitive or specific for diagnosis of iron deficiency. It's very important in a new journal from University of Cape Town. There's actually a gray area where they look at the serum ferritin level. The serum ferritin level can be 80 to up to 300, and they see that as a gray area. We can still diagnose someone with an iron deficiency. So it's very important then to look at your chronic inflammation as well as the hepcidin levels, because it can actually also present with an iron deficiency. They did a study where they actually took various patients with an iron deficiency and did the iron on the bone marrow and correlated with the ferritin level. And they've actually seen that the sensitivity and specificity increased when they used a cutoff value of 80 micrograms per liter. Just to note that, so it's very important for doctors to take the serum ferritin level with the inflammatory markers, as well as the hemoglobin content and the rest of the picture. The serum ferritin level can throw you off because it is an acute phase protein. So there's also in athletes a standard blood collection. It's preferably in the morning you have to take it between 8 and 10, usually fasting. The reason for fasting is because you don't want the patient to have been taking iron supplements or have had a meal where there's high iron, because that can actually skew or just mislead your iron interpretation, because your serum iron will be low. Saturation could also be higher. But it's best for them to rest, fasting, and also not to exercise 2 to 3 days prior to taking of the bloods. There should also be no signs of sickness or infection, just to postpone then the taking of bloods. And then iron, it's important, should be formed at the baseline of 12 p.m. It's also very important that hepcidin levels are also diurnal and they are lower in the morning. So it's also best then to, if the patient has an iron deficiency, to give iron in the mornings. So we know about laboratory diagnosis. I think all the doctors in extensive detail know it, that we'll diagnose iron deficiency, we'll look at the MCV and MCH. The MCH is more sensitive indicator for an iron deficiency than the MCV. So if you do have a patient where the MCH is low, think about doing iron studies. In a full-blown iron deficiency, you'll have low serum iron. Ferritin will also be low if there's no chronic infection. Your total iron binding capacity will be increased together with your transferrin, but your transferrin saturation would be low. And as I spoke about it, just keep in mind the gray area of ferritin level and interpret it with the clinical picture as well as the rest of your iron profile and FBC parameters. So the reason why I showed the initial present or picture of iron absorption is just to actually show why, if you're going to start with treatment of iron deficiency, it's also best to give dietary advice. It's best to explain to the patient to actually ingest heme iron in the ferrous form. As I showed with you, the absorption, there's actually a different pattern where the ferric does not need to be reduced and oxidized. So it's better absorbed, and factors that increase the absorption is better with the heme iron foods. So it's better to have the meat intake than the ones in the fruits and vegetables. So the treatment of oral iron for a normal person, it's usually this is not normal, not an athlete. For women, it's about 15 milligrams a day. For an adult man, it's a bit less, 10 milligrams. However, it's recommended more in athletes. As you can see, 17.5 in the men and 23% in women. And this is due to the increase of iron loss in exercising. So for completeness sake, I just put in some examples of oral iron tablets available. You can get ferrous sulfate, that is the most common iron tablet available, and it's just in a ferrous format. And as you can see, you can get 75 milligrams in that tablet. To note that what you need for increased demand, it will be met by the 75 milligrams. Then you can get another format, the ferrous forte, and these ferric forms is actually complemented with vitamin B12, folate, and vitamin C. And then you can get your ferric form, and this tablet has also got iron together with vitamin B12. And then you can get a chelated forms of iron. Also to note that you can see the chelated forms got low iron in one tablet, 15 milligrams. And then you have to now decide which is going to be affected for your patient. As you know, ferrous sulfate with 75 milligrams will be absorbed very good. But if there's too much, it could increase or too many has not been absorbed, can increase your gastrointestinal side effects. So this is actually the cheapest one, 22 Rand, you can say. It will increase in the type of tablets you need. As you can see, different prices. And also just to note that the chelated forms, it depends on also your patient's metabolic field. Some of the chelated forms will actually, if the gastric emptying is fast, it will actually bypasses the duodenum and jejunum and actually not be available for absorption. But it will also decrease your gastrointestinal side effects. So the advantage of being oral tablets, it's really available and cheap. But there are disadvantages if you're using too much or there's too free iron available, because it can cause free oxygen reactions and free radicals that can actually give you the side effects, and you can get constipation, nausea, diarrhea, and abdominal pain, as well as a metallic taste. So this you need to interpret with your patients, see what they can actually tolerate and what is the best to increase their iron. For completeness sake, I've also added intravenous iron therapy. This you can use in a patient that's iron deficiency poorly responding to oral iron. And this will be in a severe hemoglobin of 10. It's usually used when you want to rapidly increase your hemoglobin and ferritin levels with fewer gastrointestinal side effects. It's also associated with side effects. You can get hypophosphatemia, but it's actually the side effects with an iron transfusion is less than what you can actually get with a blood transfusion. To keep in note that this presentation is about athletes. So usually athletes are quite healthy. They're supposed to try to respond to oral iron or even sachets of iron. So iron therapy is really not supposed to be indicated in athletes. A question has been asked before that if the patient's feeling fatigued, will the iron drip actually help performance? If the patient does not have an iron deficiency, hemoglobin is normal, an iron deficiency will add no value to the athletic performance. This is also just for completeness, a type of intravenous iron we get in South Africa. We get Ferinject. It's the iron carboxymaltose that can be given intravenously in room setting with appropriate monitoring. Monofir has been actually the one getting most of the attention, and this could also be given intravenously in a room setting at one dose over a few hours. Venofir is the iron sucrose which can be given in a room. This formula you should actually receive multiple small doses in different days, so it's usually not that preferred. And Cosmifir is iron dextro, we can also be given in a single large dose over a number of hours, and usually Cosmifir requires a hospital admission. I've just put for completeness sake the time period, the side effects with the table. And also then for interesting sake, I just added the prices of the different intravenous iron. As you can see, Ferinject is 2,800 Rand. Monofir is the expensive one of 5,114. Cosmifir is 970, you can say. And Venofir is just over 1,000 Rand. So it's also quite expensive to give these IV transfusion for patients, and this is something to remember. I also know that medical aid has got issues with patients with being iron deficient to motivate to give IV iron. And it's due to the prices of iron. So you do get side effects of intravenous iron. So first of all, if there's extravasation of the iron, you can actually get permanent skin coloration, and it's best to actually stop the transfusion, try and aspirate if you can with a cannula and apply cold packs. You can also get the fishbone reaction. It's usually a complemented mediated reaction where the patient can present with flushing, myalgia or arthalgia, back pain, chest pressure, and this usually results without any pressure. You just stop the infusion and monitor the patient. And then you can also get your full-blown anaphylaxis and hypersensitivity reaction. As I mentioned before, these reactions are rare, but it can occur, and then it will be best to consider IV corticosteroid or hydrocortisone treatment, as well as an H2 antagonist. And also epinephrine, a full-blown cardiac resusc trolley should be available if the patient has this. So it's best to prevent this from happening and have a hospital setting or a setting where these drugs are available if the patient gets an anaphylactic reaction. Then just the last one that I want to talk about, the treatment can actually occur after IV iron, and it's usually hypophosphatemia. This usually occurs after 2 weeks after administration of it, and usually the patient can present with fatigue, proximal muscle weakness, bone pains, and this actually mimics the signs of an iron deficiency. So this actually occurs most when you use Ferinject. And the mechanism for that is actually it increases fibroblastic growth factor 23, and it actually decreases calciferol, decreases calcium, and it gives you like a secondary parathyroid feature causing hypophosphatemia. It's more common after more than one treatment, so patients with chronic anemia are the most at risk. And usually there's no treatment, you can stop the infusions, and it will take a time period, but it resolves spontaneously. There's research studies where they actually use a monoclonal protein or monoclonal antibody against fibroblast growth factor 23 but this is just being in research to actually prevent this from happening. It's not FDA approved for the treatment of hypophosphatemia. And then another occurrence in athletes is the March hemoglobinuria or the foot stroke hemolysis. And this name actually occurred in marching from soldiers. It was actually called March hemoglobinuria. This is from soldiers that have been marching for a few hours, actually presented with this hemolysis. And it's usually caused by the forced muscle contraction of the heel on hard surface, breaking down the red blood cells, causing hemoglobinuria. It's actually also causing the hemolysis in the plantar vessels, and it's usually, they say, if you can use a proper shoeing effect, or they actually also look at the athlete's running style, and they actually also changes the environment where they practice. You can decrease the occurrence of March hemoglobinuria, and you can also see that in these patients, if we know with distance runners, that you can see that the increase in red blood cell sizes will be higher, and the MCV will be increased. And this is actually just due to the increase in red blood cell breakdown caused by these runners' March hemoglobinuria that they actually call runners' macrocytosis. That's just a picture to indicate that shoes is very important in these to prevent March hemoglobinuria. So usually what we do is we can actually do urine analysis and we can detect hemoglobinuria. It usually resolves 3 to 5 days when they stop of exercising or jogging. And it usually will also reveal, like I said, a macrocytic anemia because of the increase in reticulocyte count and the production of red blood cells. And your haptoglobin may be low because it's binding to the hemoglobin that's been broken down. Treatment is usually not necessary. Like I said, choose the running method, and the intensity of the training program should be changed. Also to note that if you do have an athlete where the hemolysis occurring is increased, it's best also to treat these patients with iron because you know that the iron demand will increase. There is a few changes in white blood cell that can occur in athletes, and this is usually low white cell counts. So the lowest white cell counts we can get is in individuals of sports where they're cycling, actually triathlon. And also it's been reported that the white cell count is also lower in endurance type of sports compared to team-based sports. So neutropenia, you can get a neutropenia. It's actually more common in women in different journals that I read. The neutropenia can go below 1.5, actually till above 1. And there's actually a few different reasons for this. It could be due to decrease in bone production of neutrophils. It could be increase in the neutrophil destruction because of the inflammation occurring. It could also be due to muscles that's been injured, and there's a transport of your neutrophils out of the circulation to the tissues, increase in endothelial adhesions, and it could be a mix of these mechanisms causing the neutrophil. It's also important for a doctor to then monitor if you know your patient is prone to neutropenia, to actually monitor them and actually also counsel them on, proper hygienic methods, especially with fruit and vegetables. Also important to know that some African population, the neutrophil count is already low, so you have to interpret it with each patient specifically. And then important, if you do have a patient that after strenuous exercise get an episode of neutropenia, it's best to avoid drugs that can actually aggravate the neutropenia, like antihistamines, that can actually also cause a neutropenia. All the other drugs, I don't think it will probably not be that of a concern in a healthy athlete, but it's just also to keep in mind that drugs can aggravate the neutropenia. Lymphopenia has also been documented, especially post-exercise, and they've seen that the T cell function and the production decreases post high stressed hormone levels post an exercise, and they've also detected that your innate immunity with your saliva actually also decreases post exercising. So with this post-exercising, they call it as an open window for these athletes to actually get sick because there could be a decrease in your neutrophil and lymphocyte count. Just something to be aware of if you do detect it in athletes. And then one slide that I'm just going to put in for changes of platelets in the coagulation system, to keep in mind that athletes, they're quite healthy patients and the vascular system should be intact. So there should not be complications. But just to recap how platelets are being produced, it's by the process of thrombopoiesis. And I just wanted to show here that your interleukin-6 that's actually caused by inflammatory markers increase the production of platelets, as well as the EPO. EPO, so if you do have an episode of hypoxia, you can actually increase your platelet count. And also, if you do use external EPO, like recombinant EPO and drug dosing, you can get an increase in your thrombocyte count. And that's also usually why they look at the hemoglobin or the hematological parameters for patients doping, because there's actually signs that you can see if the patient did dope. So changes in the platelets of coagulation. So just to note that there is an increase in the platelet count, and this is caused by platelet release from the liver, lungs, and spleen. So you'll get a thrombocytosis of a strenuous exercise. It could also be a response to the concentration of adrenal hormones. And also to remember that your platelet count increases, but there's also increase in platelet adhesiousness and aggregation. This is due to the increase in thromboinflammation coagulation factors. So keep in mind that yes, you do get an increase in procoagulant state, but also athletes are healthy and they'll also have nitric oxide from the endothelial cells that will actually cause vessel dilatation, increases blood flow to prevent the blood clots. The problem occurs when you do have a patient with cholesterol, vascular diseases that's now going on a strenuous exercise. To keep in mind that the platelet count can increase, the coagulation factors can increase, and it could be a risk for MI or a blood clot in patients that were previously not healthy. Okay, so now I've spoken about the 3 hematological cells, and the rest of the presentation is going to be on blood doping. I've used the following journal that's very interesting actually on my blood doping information. So what is doping? So this just refers to the use of banned substances in competitive sports. And it's also known as performance enhancing drugs. It's another term used by athletes to perform their athletic performance. So as we know, we want to increase our red blood cell mass, to increase oxygen delivery, and to increase our performance. So that is actually what the athlete wants. We've got the most common way of blood doping is actually by blood transfusion, autologous or homologous, the injections of EPO, and then newly the injections of synthetic oxygen carriers. So I'm going to speak about the transfusion and the use of EPO. So what do they want, or why do they want this hemoglobin concentration to be increased? First of all, they want to increase in hemoglobin mass, that will increase your aerobic capacity, will actually then increase your heart rate, will increase your maximum cardiac output. At the end of the day, you want maximum O2 excursion, oxygen excursion, to increase your lift. So the most common type of blood doping is actually blood transfusion. We all know of a lot of athletes that's been banned before being detected by blood doping. Could be autologous or homologous transfusion. And the process, what they actually do is 3 to 5 weeks before the main sport event, they'll actually donate a unit of their own blood. What you can do if you have a proper medical facility, they'll centrifuge it, they'll remove the plasma components and actually inject them back or infuse them back into the patient, and the red blood cell content of that will be refrigerated or frozen. So hopefully if you've got the needed medical facilities, you'll freeze your red blood cells and not put it in a refrigerator. There was an Italian cyclist that did this, and he refrigerated his red blood cells. And the day of the doping, he got very sick because you need to process this accurately. Because remember, this is a site of infection. could also be a site of red blood cell breakdown, increasing your potassium, and unfortunately that athlete passed away. It was the right procedure to follow. So it could be dangerous. So it's best to do it in a medical facility and not do this and place your blood in a refrigerator. So as I mentioned, there's two types: autologous, when they take their own blood; homologous is when they receive the patient's, the donor's blood. So the World Health Organization, or the anti-doping agency, has actually got methods of detecting homologous blood transfusion. So this is not actually the way that the athletes actually want to do. They'll use their own blood. And it's actually been shown in a Dutch study that even if you transfuse a small amount of blood, 135 milliliters, in an athlete before the event, it can actually increase his performance by 4.7%. So it does work, and that is the reason why athletes want to use it. But there are detections of methods for detection of doping, and flow cytometry is the method of choice. So in the World Anti-Doping Agency, they've got the flow cytometer for actually detecting homologous transfusion of blood. And the reason how they do this is the red blood cells, not only the main blood group regions, but there's other antigens on the red blood cells, and they use a panel of 12 antigens on the red blood cells. And that you can actually mismatch quite, and you'll see two dual population of red blood cells, and then they will be able to detect these patients that received homologous blood doping. But the problem occurs when there's autologous blood doping. So there's no single test available to identify the presence if you do use your own blood, especially a small amount. The best method of detecting is where they use the athlete's biological passport. And this is an indirect method of how they monitor the entire hemoglobin parameters as well as chemical parameters to see changes in the body if there was a blood transfusion received. Another important, or actually one that a few athletes have been actually brought out, is the plasticiders used in the manufacture of these bags and tubes where used for blood donation and storage, where they can actually detect these in the urine of patients. So a few have been brought out like that. And the new methods is circulating microRNAs, changes in the hepcidin hormone if they want to monitor them quite strenuously, and also the analysis of red blood cell microparticles that's been getting a lot of attention. There's a few journals that you can see how they use microRNA, just as non-coding RNA fragments. That's actually also can indicate to you if the patient has received doping. The microparticles used from the red blood cells, it's actually very interesting, but as you store red blood cells, the red blood cell particles changes shape, and these can actually indicate if a patient has actually recently transfused themselves with their own blood after it's been refrigerated or frozen. And there's a few changes on the red blood cell surface. Your band 3 protein will actually decrease, and a few other markers on your cell will actually also, like glycophorin A, amount will decrease in a storage. So they look at these red blood cell particles and will actually see if the patient is actually, or it's indicating for a transfusion. So there's different methods for detection of it, but the most one being used today is the athletic biological passport. Also, another interesting story that I know that's a bit disturbing. There's some athletes also, because the detection of drugs in the urine, what they'll do is they'll empty their entire bladder before being tested if they know they're being tested. And they can actually, what I've heard about the one athlete, they can get actually someone else's urine in a bag, and they'll actually go to the bathroom and catheterize themselves to get clean urine. But unfortunately, the plasticiders will still be detected if you do want to take that road of decreasing your chances of being detected of doping. So the most, actually I say secret, or not a secret, but the way of detecting doping in athletes is actually using the athlete biological passport. And this is actually a program that's been implemented from 2009 by the World Anti-Doping Agency. It's actually just to detect any doping in a stronger and effective manner. And it's based on a longitudinal monitoring of biological markers at various periods of time. And it reflects the patient or the athlete's changes in biological markers over his career. So they will go and draw blood from an athlete at this most intensive training period, also when the patient or the athlete is at rest. And you won't know when the doping agency will actually go and detect or draw blood, but there's also a process where they draw blood, transport, how this been treated, and they'll actually build up a profile of this patient. Just to keep in note that I'm talking about the hematological model where they can use 12 different parameters, and they'll actually monitor these parameters of that athlete intensely. But there's also a chemical part that I did not add, where they look at the hormone profile as well as the chemical balance that could indicate if there's a doping suspicious. I now didn't feel it, but they've released formulations and computer programs of how they use your hematological parameters and how they can predict your risk of actually doping. It's quite extensive, and some of the formulations have not released to public, but that's actually the method of how they use to detect doping in most of the athletes. When everything is not corresponding to the previous history or the formula is indicating a doping, they'll actually call in the athlete and then specifically test for the doping methods that they suspect. So we all know that erythropoietin stimulating agent is another method that's used. It's the erythropoietin hormone, and it was first FDA approved for anemia associated with kidney disease in 1989. And is subsequently banned from the International Olympic Committee the year after. So it just shows the effect of increasing your EPO and the athletic performance. It's also to note that your first generation recombinant human EPO have a short half-life of 8 to 24 hours. With the more advancing and recombinant next generation of EPO stimulating, I've got longer half-lives that's due to the glycosylation at the end of the molecule. And also with modified EPO drugs available, they actually increase the molecular mass, and this also increases the half-life. The problem with the increase in the molecular mass, it's better or it's easier to detect it in the urine, as well as ELISA methods or isoelectric focusing methods. So the newer drugs are actually not that profound in doping because it's easier to be detected. But keep in note that the EPO stimulating agent is one of the most common methods used in doping. As we all know, Lance Armstrong used EPO stimulating agents, as well as autologous blood transfusion, as well as steroids. And how the EPO actually work, it just actually stimulates your increase in production of red blood cells, increasing your red blood cell mass. At the end, you get your increased O2 supply to the muscles. So it is a glycoprotein with different glycosylations depending on the size and where it's cultured. So usually recombinant human erythropoietin was initially transfected and cloned by using Chinese hamster ovary cells and subsequently produced by baby hamster kidney cells. So as you can see that there will be methods of detecting because it's not humanly produced. And by using this different glycosylation patterns, it could be detected with isoelectric focusing. So it's important to know that even though newer development of the drug, even though the drugs are being enhanced, there's actually better ways of detecting these drugs. So with EPO, there's advancement that you can use more. There's more red blood cells, increases your fitness, increases oxygen carrying capability, but there's also disadvantages where it increases your blood viscosity, can increase your risk for stroke, heart attack, DVT, as well as the increase in blood pressure. The patient can feel sick. And then very, very rare is the use of this EPO can actually, these patients can actually trigger antibody that can actually induce a pure red cell aplasia. Just to note that that's very rare, but it could be a side effect. The other use of drugs is hypoxic inducible factors. It's a dimeric molecule expressed in numerous tissues of the body. So usually what it does, it's composed about an alpha and a beta subunit. And with inside the kidney cells, the alpha unit is rapidly degraded when there's normal oxygen levels. But under conditions of hypoxia, the dimer is stabilized and transcription factor is initiated for the production of EPO. So as you can see that these factors will also be used in doping because if it's not degraded, it will increase the production of EPO. Although none of the hypoxic-inducible factors is FDA approved, but they're on clinical trials, they're already on the World Anti-Doping list of banned substances because you can get them on the black market. So one example of hypoxic-inducible factor is cobalt acts as an element of hypoxic-inducible factor alpha stabilizer, and this can actually prevent the breakdown of the alpha unit. The xenon gas is also being used to increase the production of hypoxic-inducible factor alpha. So both these agents has also been banned by the World Anti-Doping Agent list just before the increase of EPO at the end result. Just keep in mind that these drugs can also have side effects, and also known that there have been athletes banned by using these hypoxic-inducible factors, even though they're available in the black market. And very last is you can get synthetic oxygen carriers. So this is just actually made, the main aim was made, these were actually made in sites where blood transfusion not available in an emergency setting. I know it's very not readily available, but you can get hemopure, bovine-derived cross-linked acellular form of hemoglobin, as well as a perfluorocarbon emulsions that's actually used to carry oxygen. These are very rare, but it's important to know that they can also be used as doping methods if needed. Just note that athletes must be very desperate to use all these methods and to enhance their performance. Just to know that even though there are a number of methods that you can dope patient, just remember that any athlete will undoubtedly seek to gain the competitive edge over their rivals. And as novel methods of blood doping emerge, just remember novel methods of detection will also be there necessary to combat them. So doping is quite interesting. I think it is in infancy. There's a lot of new methods available, and there will be also ways that the athlete will try and prevent them from being detected. Thank you. This was a presentation to touch on some of the aspects in hematology and athletes.
Thank you so much, Michelle. Actually, interesting. It's not something many of us know a lot about. So it's very interesting. It shows the desperation of
Yes, it shows the desperation. And I mean, so many athletes has actually been caught by this. So it's actually quite a concern. And I do feel if you have probably the available medical facilities and proper doctors, it's probably available for athletes. I mean, the entire Russia team was banned because of their doping methods. So it is definitely occurring.
Yeah, and I guess at that level, depending, how advanced you are, every millisecond kind of counts. So yeah, because
I've got a question. So I think you said in your presentation, so athletes, they've got leukopenia and lymphopenia. Are they more prone to infections or not?
They're not prone to, but they can have been, if there's maybe they said that it's best to have a hygienic profile, especially in dorms where there's a lot of sport athletes, like in universities, where they can occur, they can have an increased risk of infection. So for that, it's just to explain to them after strenuous exercising hygienic methods, because you can have an increased risk, yes. But the neutrophil and everything functions normally, but they can have a boost in certain time periods. But they usually don't get sick, but there's times where you'll do an FBC and you'll see the neutropenia with no signs or symptoms, no infection. And it could be the reason for it.
Yeah. Welcome, Dr. Taban. Do you have any questions? It's muted.
Morning, Leanne. Now, thank you for the presentation, Michelle. Sorry I couldn't attend because I came yesterday late night. My question is, I think for the athletes, especially the female athletes, that really you see quite a lot from age of 14 that actually are competing in various kind of sports. the question that how frequent do we need to check their iron actually for them to get iron replacement? Because you didn't
You have to
normal,
test them.
there's no indication for that.
Yeah, it's best to have an iron profile twice a year in strenuous exercising athletes to prevent the iron deficiency of non-anemia, because that can actually also affect the performance. So it's best to do it twice a year. If that's your question.
Apart from Dr. Engelbert's question about the neutropenia in athletes, how will we know that actually this is not a cyclic neutropenia apart from the side effect of the actual athlete? Can they, would you need to exclude other cause of neutropenia before you make that conclusion?
I think you'll monitor also, and it will be with the patient's signs and symptoms. Cyclic neutropenia, they get cyclic infections also, and sometimes not. But with the monitoring of that, it will be difficult to discriminate. But you can actually test do the FBC in the period of rest and see if the neutrophil count is also normal. Then you can discriminate that it's most likely exercise. It could still be cyclic, but test them in a rest period as well.
My question is, at what level, how low does it actually go?
There's different references. So you can get a women's go lower than men. So CSPA over 1 to about 1.6. So
But either way, it is only 1, 2.
Yeah.
It's not much lower than that.
Yes.
So that reduces the risk of infections actually.
But you'll still, it's quite alarming for some doctors to see a neutropenia in a healthy patient. That could be the cause.
So, and then last comment about what about those athletes that feel fatigued with normal iron profile, and they go into iron booster? Would there be pro-interaction with the overdose with the vitamins like vitamin C and the vitamin B in their system that could have make them very fatigued?
Just know that if you're not iron deficient, everything is normal. The use of iron supplements can actually increase your side effects of gastrointestinal side effects and actually make you sicker. So there's no value of supplementing iron if the patient's got no iron deficiency. With the vitamin C, I don't think it's going to be affected. It could actually just increase the immune system. But with the vitamin B12, if you overuse it, you're just going to urinate it out, and the values will be high if you do tests for it. So it's usually not recommended. I will just, educate on dietary preferences. And it's also just to note that iron drip is really contraindicated in the athletes that are not anemic. They can actually feel sicker if they get hypophosphatemia.
Thank you. I appreciate it.
Just a few comments, apologies for being late a minute. The high altitude training is quite a popular way of a physiological way of increasing the red blood cell mass, because I know in the Austrian is quite a popular place to train there. There's no way, there's nothing that prohibits that. That is a physiological mechanism.
Yeah, I know they also ask about the areas where they train, because obviously the hemoglobin parameters will be differently. But if you're used to training in that altitude, your HP and your parameters should actually stay the same. If there's a change in your environment, it will actually also increase it, and then the doping agency will detect it. But if there's an explanation for it, they can valid for it. So yes, it's do affect the
But it's allowed.
Yes.
Nothing stops you from doing that.
Yeah, nothing else, yeah. I think Gerda Stein, she trained quite a lot in Boston with our altitude training. Other thing is the drug you mentioned, a few drugs, the serial fault IL. It's a mitochondrial way of iron absorption. They say it's a better drug with less side effects. Have you guys have experience?
Yeah, so they do say that the Cideral and the Quadrifer that they've released are better iron absorption with least side effects. However, I personally have used Quadrifer and I've had severe side effects. So it depends from person to person.
And also the way if this you think of alternative day treatment and everyday treatment, the better absorption with alternative treatment. And the last question, Michelle, is when you have after iron transfusion, how long must you wait before you actually draw the blood? Because that also a differ.
Yeah, so according to the journal from Cape Town, they said it's best to actually not to do your iron profile within a month after you've received the iron transfer, because it's going to affect your values. So I'll say a month, and also they say taking iron tablets to stop 24 hours before testing your iron profile.
I also have like this. That's just to confirm that.
Yeah. But that one journal of Cape Town, I will recommend everybody, if you've got patients where the iron studies is a bit confusing, they actually give nice clinical cases at the end also with examples. So it's actually quite nice.
There's also quite frequently also when the doctor starts a patient on iron treatment, how long must they wait before he can test not specifically the ferritin but the impact but hemoglobin. So you should sit in about 10 to 14 days.
The reason is you want your hemoglobin to increase. If I can tell you, if you've got an anemia and you give your iron supplements, the hemoglobin should increase by 1 gram per deciliter within 2 weeks. So you'll continue until your hemoglobin is actually valued and the patient will also feel better. But it will be best to actually continue 3 to 6 months after receiving your main, and then you know the patient is responding.
I think that's quite obvious, a quick way to test. Does the patient responds about 1 gram per deciliter in
So
2 weeks?
Maybe in a month.
Yes, it doesn't help to test before 2 weeks. I think that's not preferable, but
I think it also depends on the level of hemoglobin, obviously, how low it is, then you would measure more regularly. What I've seen in practice is that we know traditionally iron stores fully replaced needs to be on a full dose iron supplementation for 3 months at least. Thereafter you can put them on a maintenance dose. Depending on the hemoglobin level, you measure them regularly or not. It's not always feasible, practically. You'd call them once a month, I think, if it's not that low. And you'd measure it with the iron levels as well, just to see that there is an increment.
And then you also not communicate with the patient if the side effects are too severe and the HB is low.
Because compliance is an issue.
When these drugs weren't available, and we also recommend only ferrous sulfate was available in the 80s. So I ferrous sulfate now I have to give it 6 months and that's that before you do anything. Didn't take just.
But ferrous sulfate, you'll find, is still one of the most effective iron supplementation. You can see all of these irons, they're so expensive, but they're not, the elemental iron in them is not sufficient, and people just see them once a day,
Because you need at least about 75 milligrams of elemental iron to treat it properly.
They say even 80 to 100 milligrams of iron per day.
But it's a minimum, but a lot of these drugs, as you said, it is only for prophylactic, doesn't contain enough elements to treat it.
I think, as I mentioned before, like the iron, it's also like the most important thing that you're actually going to be successful on oral iron is that the patient needs to take it consistently.
And also the other drugs that they're using, like the PPI.
Yeah, because the other problem is everyone is on PPI. So that also influences the absorption of because you need ferric iron.
Yes.
Needs to be converted from ferrous to ferric. And you don't get it with the PPIs.
Previously with only ferrous sulfate, because it's cheap, I think the most problem or the most common reason for compliance was non-compliance it's not working, it was non-compliance. Not because that the patient that it was the ongoing course, but the non-compliance was the biggest reason for the failure of treatment.
Thank you very much. If there's no more questions or comments, thank you and enjoy the rest of your week.
Bye.